It's time to get the story behind the story. Interviews with newsmakers, news breakers, and Vermonters making a difference. WCAX presents 802 News with Mark Johnson. Here's Mark.
The Howard Center in Burlington serves as a key part of the community's social service safety net. Many of the 1,600 counselors and staff who work there deal with two of today's most pressing needs: helping people to stop using drugs and aiding those who are experiencing mental health challenges. While the number of clients the Howard Center serves hasn't increased dramatically, leaders there say the complexity and acuity of the cases have deepened. People are using more powerful illegal drugs that can be more difficult to stop using. Some of those with mental health issues are also using drugs, and many are dealing with another one of today's most difficult and profound problems: the availability and cost of finding a place to sleep and call home. In this edition of 802 News, I spoke with three key leaders at the Howard Center: Beth Holden, Chief of Client Services; Dan Hall, Director of Outpatient Services; and Dr. Heidi Melbostad, Director of the Chittenden Clinic. We didn't solve any problems, but I think you'll come away with a better understanding of the big challenges the Howard Center staff and their clients are facing every day, including those who sometimes make us uncomfortable in public places in Burlington and other communities throughout Vermont. We want to thank our sponsor, Red Hen Baking Company, who helps make this program possible. We are here at the Howard Center in Burlington, and we have some folks who've been kind enough to join us here who I hope can shed some light on some of the important issues out there. Let me start with you, Beth. And the reason I'm here and the questions that I'm hoping to have you help all of us better understand is that it seems, and maybe it's a perception, maybe it's real, it seems as though there is just a profound number of people who are suffering from mental health issues out there. And, some people are using the word crisis. Is that a word you would use?
Here at Howard Center, I think the way that we're looking at our current community, and when we think about mental health crisis, we also think about substance use crisis, because it's hard to separate those two things. And most people don't just have one or the other. Most people have many things going on, including substances and mental health problems, as well as social service needs. Is it a crisis? Perception-wise, I understand why people see it as a crisis. I think a couple things are going on right now. One is the way situations are portrayed in the media. Everything looks terrible. All the negative and horrific things are discussed and talked about. That's not to deny things are going on. We hear from schools as well. Children are suffering. We hear a lot about social media. Children are not doing well. The pandemic didn't help any of it. What I think also happens, though, is people are coming forward more than they used to in their own self-report and disclosing what's going on for them. That's a good thing. But that skews our look at the data around, is it more or are just more people coming forward? The other thing that I think happens is there's people forget of all the good work that is happening and the number of people that get served. We can talk about our organization. We serve about 19,000 clients a year, and that's a lot of people who are responding to treatment and doing well. So I think the problem with how this is being described is there's not a balanced view of what's going on. And there's easy comments: the system is broken, the system is falling apart, nothing is working. Is that accurate, or is it that our system needs to evolve and it doesn't evolve as quickly as the problems present in our communities? So I don't think we need to throw everything out because many things are working. Heidi will share more with us about the Chittenden Clinic, but when folks, for example, say, hubs aren't working anymore, the methadone clinic's not working anymore, that's not accurate. Either we have 900 people to tell you otherwise. So I think we would really want to encourage people to have a balanced view of what's happening.
Are the numbers actually up?
No. The numbers are similar to pre-pandemic. Some numbers are down. Our programs will tell you that referrals are down. that there's not as many people seeking services. So that brings us to a lot of questions. Are people not accessing services for some reason? There's a belief that if you have a mental health or substance use disorder, you want to get treatment. That's not necessarily true. People may not be at a ready point to access treatment for whatever they're struggling with.
What's the connection between the opioid problem and mental health issues? Heidi, you want to take that one on?
Yeah, and I would also add that we haven't had a change in the number of people that are showing up for treatment, as Beth mentioned, but I think what we have noticed is a change in acuity. And I think that that does make a difference in our community. And so when you think about the intersection of mental health issues and opioid use or other substance use, of course they're related, right? And so if somebody has an addiction to opioids, to stimulants, now we're seeing xylazine in the community, and they're taking those substances and they have an underlying mental health issue, they have depression, anxiety, they have a history of abuse and trauma, it's all connected, right? And it's very difficult to treat mental health issues if people's physical needs aren't being met. So if people don't have housing, and if they're downtown in the park and they're hanging out there all day long, we have therapeutic services at the clinic. We have master's level clinicians at the clinic. They often aren't able to do therapy as we think of it traditionally, coming in 1 hour a week, because they're trying to do a lot of care coordination and case management for people to help them with housing, to help them with food insecurity, to help them get connected to primary care providers, because now they have wounds from the xylazine that they're using.
Are people that are using opioids, is this self-medicating for people that have a mental health issue? Is this self-medicating? Is that why they're using these substances?
I think that sometimes it's oversimplified and it's explained in that way, but I think it's actually much more complicated. But absolutely, if you are suffering in your life, if you are experiencing feelings in a state that is so intolerable and you have an opportunity to not feel that way anymore through substance use, it makes sense that people would use substances to not feel that way anymore.
Tell me how it's more complicated than that.
Because I think that sometimes when it's framed that way, it's as if there's an explicit moment and a determination that someone has is, wow, I feel really depressed. I'm having memories of being abused by a partner. I'm having memories of a family. I'm having memories of losing my housing. So therefore, I'm going to go out today and I'm going to go and start using opioids, and I'm going to start doing it intravenously. And so I think that the complexity is that it tends to be gradual. I've yet to meet somebody that is in treatment at the clinic that has said to me, yes, my goal was to start using opioids intravenously. No one ever, starts out that way. It's gradual, right? So I think there's complexity too, because if it was simple, then there would be much easier treatment outcomes, right? And we know that addiction it's recurring. It takes a long time for people to achieve recovery. It doesn't happen overnight. And so I think that there's a lot of factors that influence it.
Can you explain to people what's the hub?
Sure. So in the state of Vermont, there are 8 hubs. And what a hub is it's an opioid treatment program. Opioid treatment programs are regulated by the federal government, by the Substance Abuse and Mental Health Service Agency. We have 8 of them here. So it's a physical location that people can go to receive either methadone or buprenorphine in the treatment of opioid use disorder. So for Chittenden County, the Chittenden Clinic at Howard Center is the designated hub. It was called that because as it sounds, it's a place for people to go to get a number of services. So at the clinic, we have case management, we have nursing, we have medical staff, we have clinical staff. And then originally when it was developed, the theory was you would start at a hub and then you would transfer out to a spoke. And a spoke is a place in the community, maybe a primary care provider, an independent provider that prescribes buprenorphine. So at the hub, that is the only place that you can receive methadone. And so when I talked earlier about acuity, what we're noticing is that more people are interested in receiving methadone than buprenorphine, although overall the number of people in treatment hasn't changed. And so in our county, the only place to get methadone treatment is at the clinic.
Educate me. What's the difference between those two?
So there are two different types of medication. They are both opioids. One of them, without getting too scientific, one of them is a full agonist and one of them is a partial agonist, which it's how it binds to the receptors in the brain. And so what we know about buprenorphine is that if you have ongoing illicit use and you start buprenorphine, because of the pharmacology, because of the binding in the brain, it will actually precipitate withdrawal symptoms. So previous to what's going on right now with the fentanyl epidemic, that people, if they used heroin, if they used prescription opioids, they would stop. They would then go to treatment. They hadn't been using in a while. Their receptors didn't have any like opioids bound. They could start buprenorphine. It's an excellent treatment. It works very well. However, now with people still using, if you try to start buprenorphine, essentially that medication kicks out the substance that, say, the fentanyl that's in the receptors, and that causes withdrawal symptoms. So nobody wants to start on buprenorphine if they're still using. So part of the shift that we're seeing is more people are going to the clinic to get methadone. And initially when the hub and spoke system was created, the thinking was you go to the hub, you get stable, and then you move on to spokes. Well, now there's nowhere else for people to go in the community to get methadone except for the clinic.
Wow. Okay. Dan, let me get you in on this conversation too. So, I guess I'm a little surprised to hear that the numbers are actually down. So why do you think it is that there seems to be this perception out there that this is just much worse than it's ever been, and really scooch right in there?
Well, a couple things, and one is both Beth and Heidi alluded to this, is that the complexity and acuity is absolutely, in my perception, higher than it has been before. So the complexity of needs are significant, and then the other piece, which we haven't touched on directly, is the toxicity of the drugs out there are just so toxic and so lethal. And so what we're seeing is overdose death, emergency response to overdose, some pretty, to the uneducated or uninformed person, pretty scary presentations in the community. Scary as in it's not normal behavior. It looks strange, and so those pieces, I think, really skew the view to how this is. I mean, but the fact is, the toxicity is, and the lethality of these drugs is way worse than it's ever been. The days of heroin are really over, and so I think that's a big piece of it. Why
are more? And I don't want this whole conversation to be about drugs, but this is an important issue. Why are more people using non-heroin type drugs? What's the appeal?
Because the effect, the perceived positive effect, is much faster and much more intense. You talk to anyone who's used substances, it's always looking for the next high and the next better high and chasing that, and fentanyl is able to create a more quick onset and a more intense high.
Beth, let's go back to, you mentioned the pandemic. And I've talked to kids, I've talked to adults, and it does seem as though it's profound how that's affected people. I mean, we're all kind of, I guess, in a state of siege to some degree. So what's been the effect in terms of the types of mental health issues people are facing and how you folks all deal with them?
Mm-hmm. I think during the pandemic, when it was identified as a national emergency, and certainly an emergency here in Vermont, there was an all-hands-on-deck approach. I think as an agency, we managed it very well in keeping everyone safe, keeping our staff notified, keeping our clients notified. We switched to telehealth pretty easily, so you can see your provider through a screen. You don't have to see them face-to-face. And people were adjusting. And then time went on, and time went on, and time went on, right? When we first heard about the pandemic, we'll be okay in 2 weeks, and we're moving on. So here we are, years later, right? The national emergency is deemed over. However, when you talk with folks, that's not true. COVID is alive and well. People are still getting sick. We still have staff getting sick all the time. We're trying to protect our staff and our clients. So I think what has happened is not post-pandemic, but post-emergency pandemic, we are dealing with how do we work now? What do hybrid workplaces look like? What do people need in terms of services? We're a forward-facing business. We tend to see people face-to-face, and some people really like to not be seen face-to-face. So we're navigating that. I think we always try to keep in mind our staff are people too. Dan, Heidi, and I are people too. We all suffer with the same things that everybody else does. So when you hear about the acuity that both Heidi and Dan are talking about, think about that with all our staff. So we have direct service staff. We have young people starting fresh out of school. We have many positions that do very hard work, and they're dealing with their own mental health problems themselves and trying to cope. So I think from an organization perspective and from us, a leadership perspective, we're trying to manage it all to keep everybody healthy, because we need healthy staff to be taking care of our clients that are also trying to get healthy. I think about kids and teens a little bit differently than adults, yet we're all facing the same problems. I think children, and I just talked to somebody the other day, that whether you're a little one and you don't know how to sit in a circle anymore or share toys or follow the rules, let's developmentally move through that scale. You're a college student, you've been home for 2 years, and your parents are over your shoulder every second helping you navigate college courses, right? So I think we've had a little bit of an arrested development for everybody through the pandemic, and we're catching up. So there's some catch up. And when you are struggling with a mental health issue or a substance use disorder, your development could be stunted a little bit more. So there's always that layering effect of what you're dealing with to move to the next place in your life, the next healthy part. So I think for us, now is an incredibly challenging time compared to when we were first in lockdown. We're facing many more challenges right now.
What can you do for students? I taught a course at Champlain and had 17 kids in the class, and there were a half a dozen I was concerned about.
And we hear that every day from schools, right? Schools are set up to educate our youth, not take care of social needs, human service needs, counseling needs, and that's just not true anymore. Schools are where kids are through the ages, right? Through little kids. We can start with daycares for small children. That's where they are. That's where they need to get their services. That's where they need to get attention. So I've been really impressed with our local schools, particularly high schools, that have a lot of mental health organizations, student run, usually there's a faculty member involved, that really are helping decrease the stigma for youth that it's okay not to be okay. You know, that's turning into a bit of a trite statement, but there's a lot of truth to that. Kids talk to each other, kids respect each other. So I think the more we decrease stigma, the more kids are likely to come forward and go to somebody that they trust. And it really doesn't matter who they go to, caregiver, parent, teacher, baseball coach, person from their faith community, right? We know a lot about if youth can find one healthy adult that's in their corner and supporting them, they're going to go much further in life and they're going to have a much healthier trajectory.
Mm-hmm. Dan, I saw you nodding your head over there. Why?
Community partnerships are a huge strategy and a huge effective strategy, and I think something Howard Center does really well is whenever you can embed services in an agency or a school or a practice where that person is already receiving services, your outcomes and your ability to reduce barriers for that person to get mental health and SUD treatment is much greater. So the community partnership, I think, is a key piece in helping clients receive those services, whether it's a school or a church or a courthouse or wherever that client may be already going. If there's an identified person to provide those services there, it's an easy handoff and an effective strategy.
Heidi, maybe you can talk a little bit about this. One of the things that I'm noticing is that, people are talking about people with mental health issues almost as though they've got a problem that is causing people a problem, say, going downtown. And I understand the concern, but there seems to be almost a lack of empathy that's involved in this. And I don't know how you get people to look at people who are struggling in a different way.
Yeah, I think it's a great question. And where I tend to start is, understandably, people are really fatigued, I think, and exhausted by seeing their downtown behaving and looking in a way that maybe it didn't in the past. And I think when you get uncomfortable and when you start to feel afraid, you're going to lose compassion, right? So we know that downtown, the way that people are behaving, just the other day I had a friend ask me, she said she was going downtown through the park and said, I looked over and saw somebody urinating in the corner, and then it looked like they were taking out a crack pipe. Is that what goes on now in downtown? And I said, it can. And so I think that people are being exposed to things that maybe have always occurred, but they have never seen before. And it's right in front of them, and people don't know what to do. And I think some of the frustration maybe with downtown is business owners. If you have somebody that's intoxicated, under the influence, not aware of what's going on, and slumped over in the corner in front of your door to your shop, I can understand how that could be really overwhelming. So I think there's some kind of competing priorities, right? The businesses are there, they want to stay there, they want to be able to make money. So I think what I encourage people to do is to not turn their back on people and to not start pointing the finger. And the more that we say them, oh, those people, oh, those users, oh, what are they doing? And the more that we can say, well, why are they there? And where else could they go? And, I think if we have some curiosity, and if we think together as a community how we can support the people as opposed to separating from them, I think that's a more effective strategy.
What can we do as a community that would be helpful?
I think one thing that I love about Burlington is the community that we have, and I think that Howard plays a really large part in that. So there are community meetings that happen. There's meetings that the mayor has that he pulls a lot of stakeholders together. There's meetings that businesses have had, and then they've asked Howard, they've asked UVM, they've asked other agencies, can you please provide support? Can you please provide training? So I think the more that people are talking, the more that people are outreaching, say places like Howard, like UVM, the more that they're looking for resources, the more that they're communicating with the police, the more that they're communicating with street and community outreach, to the more that they're talking to, say, like the people that are part of the politics in downtown, and asking for, a response. How can we help? How can we address this? I think that's, ways that we can respond.
We'll continue our discussion with Beth Holden, Chief of Client Services, Dan Hall, Director of Outpatient Services, and Dr. Heidi Melbostad, Director of the Chittenden Clinic, all with the Howard Center. We'll do that right after a word from our sponsor. At Red Hen Baking Company, they believe pure, uncomplicated ingredients in the hands of skilled artisans are the building blocks for great food. They're dedicated to creating the best food from the best ingredients. You'll find an ever-changing lineup of delicious pastries, sandwiches, and soups at their beautiful cafe off Route 2 in Middlesex, just off I-89. Their breads are also available in many other locations. Led by owners Randy George and Eliza Kane, Red Hen Baking Company has been on the leading edge of the local food movement since 1999. Back to our discussion with three key leaders at the Howard Center of Burlington. Beth, are the mental health issues that people are facing different than they were 5 years ago? I mean, you're saying that the numbers of people who are struggling hasn't changed, but are the types of mental illnesses that people are dealing with different?
I think it brings us back to acuity again. I think depression is depression, anxiety is anxiety. Major psychotic disorders are major psychotic disorders. But if you start to overlay those things and people have multiple things going on, on top of homelessness, on top of poverty, on top of food insecurity. Each person has a different picture and a different profile. So I think what we're experiencing and seeing, the layering of all these problems that folks are having is much greater than we've seen in the past.
Any ideas why that might be?
I think our drug supply has something to do with it. I think the toxicity within our drug supply and how much people don't really control what they're using, and as much as we try to support them in using safely, because we believe a lot in harm reduction, that doesn't always happen. I think for good old-fashioned straight mental health problems, I think it's a matter of really getting people access to services quickly when they need them. I think that's something we work on all the time and try to track very well of how quickly we can get someone in. There's a readiness factor, and when someone is ready to actually get help and do it, we want to be there and welcome them to get on the right track.
If you see somebody in downtown Burlington, for example, who clearly is having a mental health issue, so what do you do?
So if you're somebody like me, you probably go up to them and say, "Hi, how you doing? Can I help?" That's not the average citizen, though, right? I've been doing this for a really long time and have some training. I think when people experience fear, there's an assumption that if someone is different, they are dangerous. And I think that's a myth we do our best to dispel, that if you're having a mental health crisis, it doesn't necessarily mean that you're dangerous. And we always see the very scary things that happen. There are people with mental illness that do dangerous things. That is not the norm. People with mental illness are much more likely to be victimized than to harm someone else. So for the average person, I do think it is the caring compassion that can happen, of a hello, how are you, can I do? There's also reaching out to crisis teams or outreach teams. If you're not the person comfortable to do it, can you get somebody else? Because maybe somebody else is not seeing them. We have people downtown all the time. So if somebody is really struggling on Church Street, it's very likely our street outreach team knows about that. And whether it's a shopkeeper that will call them or the police will call them, it's pretty likely that somebody will be there. You may not be downtown. You may be at the grocery store. You may be at a local park. So I encourage people to differentiate between feeling uncomfortable and feeling unsafe.
I'm just thinking people listening to this are saying, yeah, but the path of least resistance, the safest thing for me to do is maybe not engage with somebody like that.
That's a choice. That's an option that people may need to make. But could you make a phone call? I can't engage with you right now, but could I call a crisis line? Could I call dispatch at the police station and say what you're seeing? Many of our local shopkeepers downtown are well connected to our services. You may walk into a shop and say, hey, who do you usually call when you see somebody who's struggling?
Do you have more people downtown than in prior years? Give me some sense of that.
We wish we did. This ties us into a funding problem, that we don't have enough funding to keep our services as active as we like. Our street outreach team, for example, isn't fully covered by the finances and the revenue we get for those services. So that's a more complex conversation around how does the designated agency get properly funded to cover the services that we need. And then from there, then we can talk about expansion, and then we can talk about what other creative and innovative ideas that we have. But we can't support our existing programs now.
Why?
So Howard Center is fully 98% funded by Medicaid. So those are the rates we get that get set every year. And that is how we generate our revenue. Our highest expense is staff. So salaries is what we are not, we don't have a lot of perks here. We don't have a lot of extras. We have great health insurance. We have a great wellness program. You know, we do a lot of things to try to attract people to work here at Howard Center. But our primary expense is paying our staff. and the funding has just been stalled year after year after year.
Do you have enough people that are willing to do this work?
Not as many as we'd like. We are working on not only recruitment but retention. We want to keep the people that we have. That's another complication of our organization, that this is very hard work. And as we talked about earlier, you can have a very, very high-stress job, or you can go slice bagels and make sandwiches for $25 an hour. No offense to the bagel industry. This is just the reality of the differences, and we have a different workforce now. We have, speaking of younger people that are just in their first professional jobs, maybe finishing high school, maybe finishing college, there's a very different work-life balance view than when I started 20 years ago, 30 years ago. It's just different. So I think our workforce is also catching up with how do we meet the needs of our workforce. It's really challenging right now, and it's very expensive to live here. So we have young people starting out, and it's not all young people. I don't mean to be ageist. It could be anybody, but if you come here from other states, which is what we need to do, we need to recruit from beyond Vermont, then they can't afford to live here. Or you need roommates, and you're developmentally well past the age that you need a roommate anymore. So it's a pretty complicated problem we're trying to tackle on many fronts.
You need to help me understand this a little bit better with this acuity and complexity. Why are mental health issues today? Are we going back to the same issue with the drugs? Is it something else?
I think Beth was talking about the layering. There's just multitude of stressors, a lot of them related to the pandemic, but whether it's poverty, cost of living, the access to services with the workforce challenges that are going on. I think it's the multitude of those stressors have really, when people are stressed, it comes out in different ways, and one of those is mental health symptoms, and one of the ways of coping with those is substance uses. So I do really think it is that layering of the different psychosocial pieces that are going on right now. Yeah, and everything seems to be decisive, whether it's politics or whatever, everything is decisive. So I think, there's just all of these pieces that are impacting folks, and, we react to stress in different ways. And if you have a pre-existing condition, or if you haven't historically, but it's emerging now as these stressors mount, as we shift into kind of solutions, it really is a multi-pronged, it really needs to be innovative, and there is not a single answer, and it's about a lot of different agencies and entities coming together to provide an array of different interventions.
I would add to that as well that, we don't give up. You don't give up. We believe treatment works. We believe people can get well. It will help all of us to stop pointing fingers around it's the state's fault, it's Howard Center's fault, it's the police's fault, it's the hospital's fault. It's no one's fault. Could we just start there? And how do we have a collective community response, which I think we improve upon every day. Heidi mentioned a group that the mayor pulls together to have stakeholders at. I think there's a lot of those groups going on. And I think the other part, though, is everybody kind of has their slice and their part versus one coordinated effort of what we're all working on. It's very hard to do because the mental health system is very complicated. And ironically, the mental health system and the substance abuse system are two separate organizations. And if we want to add developmental disabilities to that, that's a third organization. So we are, as a system, are set up in silos. Our funding comes in as silos when our people are not silos. Our people are one person and could have a multitude of problems. We want to treat the person. We want to treat the whole person and figure out what it is that they need. But we're telling you sort of the hard parts, but there's very good parts too. There's many committed people who work here that will fight the fight every day, and people do get well, and harm reduction works. And when harm reduction works, less people die. So again, I think the more we can just keep putting it out there that we need a balanced view and we need a collective community response, we're going to keep getting ahead of the game.
What's the success rate that you're having at the hub?
So I think what's really interesting about the hub, so I've been in my position for about 2.5 years. So I came in during the pandemic. And what I find so interesting about the pandemic and opioid treatment is that in some ways the pandemic was the silver lining for opioid treatment, because all of the federal regulations that previously had been so strict in terms of how people receive their medication, the amount of medication they could have, the criteria to take home medication rather than having to go to the clinic every day, all that loosened, right? And that now our federal government has that leniency that we had with the Federal Declaration of the Emergency Status. That's now permanent. So when I think about the successes that we're having at the hub, I focus on treatment engagement and then treatment retention, right? And the hub, we have a lot of really great community partners. We partner with people at the emergency department at UVMMC. We partner with so many different social service programs within the community. When you think about maybe the pods, when you think about economic services, when you think about all the great organizations that are providing food, shelter, that are supporting people that have been victims of violence. So to me, success is when we are all working collectively together and we are supporting the clients continue to be in treatment, to have success in their recovery, whether that's abstaining from all use, whether that's cutting down on use. I also think that success looks like people that started in treatment, had no housing, had no support, and suddenly they've obtained housing. Maybe they're at the pods, or there's another program that has provided a subsidy for them. I think we certainly have a lot of work to do. It's not easy work, but I think that there are clients that are thriving in spite of the toxic drug supply, in spite of staffing issues that we might have, in spite of funding issues that we might have. So to me, success looks like the client that showed up on Monday and they come back on Tuesday.
Talk a little bit about the pods. I hear mixed reactions from people who live near there don't seem to be that enthusiastic. Mm-hmm. I hear others say, it's better than nothing. Mm-hmm. What's your view?
Well, I think you were asking about what's going on in the community. And to me, one of the primary factors in the changing with the acuity and the complexity is the lack of housing. If people do not have a safe place to stay and to live, it's almost impossible for them to have success in other parts of their lives, right? I don't know much about the pods. I don't deal with them directly. I think that overall, the idea was to try to find a place for people to go to obtain housing relatively quickly. And I think just like at the Chittenden Clinic, when it first started back in 2002, South Burlington High School is right next to the clinic. Mm-hmm. And the neighborhood had, my understanding, a whole lot to say about a hub going into that neighborhood. So I think that, you're getting people that show up at the pods maybe that are more unstable, maybe have ongoing substance use, maybe have untreated health issues, mental health issues. And so there could be behavior and activities and things that come up that could be a little bit jarring for the neighborhood. And I think we can't all have the attitude of not here, not in my neighborhood, but then where? We are a community, we are all connected, and we all have to work together in order to support the thriving of our community.
What about this very controversial idea of safe injection sites? Throw this one to Beth, huh?
This is a controversial one. We're paying very close attention to what is happening in our state and nationally. As I've mentioned before, we believe in harm reduction. A safe injection site is another version of harm reduction. So anything that is a life-saving measure, we support. The complexity around law, federally, and state is something we have to pay attention to. So we have made no commitment or decision one way or the other what our role will be if safe injection sites get passed in Vermont, but we're paying close attention. We're a private nonprofit. That's a status that's important that we can't lose. And if we go against federal regulations, there's a risk that we could lose that status. So it's very complicated. And again, from a treatment perspective, we want people to live. And what we know about safe injection sites is that survival rates are higher, neighborhood crime goes down, and it's been very successful in many other parts of the country. And Canada, we've done visits up in Canada to see some sites. So that's our position today, and we're going to keep paying attention to how this develops.
I've heard people out in the community also ask the question of whether or not it makes sense to have a facility, maybe not bring back Waterbury, but something like that, a place where people could be, as opposed to being out on the street.
The question comes up a lot, and I think sometimes there's a wish that folks that may look different in our community, they could be struggling with mental health, they could be struggling with substance use. There might be a wish, can we put them somewhere? Can they go somewhere? Now, sometimes that is said with a great deal of compassion. That person is suffering, that person needs help, that person's not able to make their own decisions. Sometimes maybe with a little less compassion, and I just don't want to see it anymore. I don't think those opposite sides are going to go away, but I think what most people don't understand is law, and there is no way to mandate drug and alcohol treatment unless you're federally mandated. There is a loophole, but we can't order people to treatment. It's voluntary. People have their own agency and self-determination. Many people don't agree with that. This week I've had conversations with several leaders in our community that will argue, but they can't make the decisions. The days of going back to locking people up in hospitals, I think, are long over. The state hospital has closed, Brandon Training School has closed. I don't think we're going back to those days. But do we have progressive, safe treatment options where people may wish to go, where people may choose to go? It's very complicated right now. Many say there's not enough beds in our state to serve the needs of people. That could be true. When it comes to mental health, there is a way to put people in the hospital involuntarily. We call them emergency exams, we call them EEs, but it's very, very strict criteria. So somebody has to be exhibiting dangerous to themselves or someone else here and now. It's a legal process. It involves a doctor, it involves a crisis clinician, or if those folks aren't available, we can ask for a warrant that has to go through a judge. And that allows the police to support us in getting a person to an emergency room for an emergency exam. Somebody said to me recently, well, has the law changed? And the answer is no. The law has not changed in many, many years. But the interpretation of the law probably has shifted. So when my first job at Howard Center was as a crisis clinician, I did many emergency exams to support people to get into the hospital, but it was involuntarily against their will. And that was 30 years ago when I started, and the law hasn't changed from then to now. We've had some language changes in the statute, but the interpretation is much stricter now than it was 30 years ago. And that's because we don't want to go back to those days where people were held against their will, didn't have say, and didn't have autonomy. We have very strong advocates within the state of Vermont for rights. So I don't know how we will resolve that as a community, because the people draw lines pretty quickly on where they stand on that position.
What would be in the best interest of people who are suffering from a mental illness, though?
You might have to ask them.
But what if they're not capable of answering that question?
I think there would be an argument that there are mental florid active symptoms of mental illness does not exist all the time. And I think when folks are well and doing pretty well in their life, many folks write up crisis plans that state certain things. When ABC happens and I'm showing signs of symptoms, perhaps I go off my medication, they have a close person in their life that is sort of their proxy, not necessarily a legal person, and they can sort of set up for themselves what they want to have happen. And whether you are having florid symptoms or not, you still have a voice of what you can do and what you're willing to do unless you're exhibiting dangerousness to yourself or someone else. And I mean imminent dangerousness that we can prove and show.
What worries you most when it comes to the work that you do?
I would say a trend that continues in a direction where kind of coping mechanisms and resources are more dangerous. So what I mean by that is this acuity, this complexity we've talked about, the way to manage those becomes more and more dangerous, and so that we're just continuing to deal with increased lethality, increased negative outcomes. So I think that is what concerns me, is that these stressors don't seem to be lifting, and if anything, there's different stressors, different types of stressors, and really the ways people are coping with them has become just either more dangerous or more maladaptive. So I think, seeing that trend continue like that is scary. The way we are seeing folks manage some of these stressors or some of these mental health symptoms, for example, the substance use and the toxicity of drugs, it's just become more and more dangerous. And so even just experimental use or trying a different mechanism could have more immediate effects that are more dangerous than I think historically, where there wasn't such an intense or significant result of that.
Things like xylazine.
Sure.
Yeah. Heidi, what keeps you up at night?
Xylazine is a good one. I think about it in two different ways. I think about what Dan was talking about in terms of clients, and then I think about it in terms of staff. So in terms of clients, what keeps me up is that the need keeps growing, and it feels like it's growing in orders of magnitude, and the resources that we have available don't feel like they are keeping on par with the need. So I am up at night when I think about the client that's showing up that has nowhere else to go, that showed up at 6:15 on a Monday morning to try to get warm, to get their medication. We have a drop-in room, they can get some coffee, but we are not a warming shelter. And we're trying to support them to get housing, so they call 211. But there's no housing available in our county, or north, or south. And so then we offer the warming shelter, but they can't get to the warming shelter, so they're probably gonna have to walk. Or maybe they're gonna try to take the bus. And they get to the warming shelter, but there's no availability there. And then they come in and see us again on Tuesday and tell us that they slept outside in a tent. So those are things that keep me up, and I know that that also keeps our staff up. So the staff are seeing so much suffering with many of our clients. They're not getting their physical needs met. The xylazine we just mentioned is causing wounds. The housing doesn't feel like it's existent. And then staff are just sitting there having to say to a client, we don't have any other options right now. We've exhausted every option. We've done everything that we were supposed to do, and we still don't have any other solutions for you right now, and we're closing in 15 minutes. So staff then have to go home with that. So I think that staff retention, staff well-being, self-care for them, that definitely keeps me up. I think about how much they're having to absorb, how much they're witnessing, and how they're managing that. And then also, the clients.
God, this sounds just like the conversation I had with the EMTs in Burlington, the same conversation I had with nurses up at UVM.
Mm-hmm.
I mean, the burnout rate just seems to be the heat just seems to be turning up and up and up in these types of professions.
I think it is for many people, and I think given the needs in the community, how could it not, right? And the need keeps growing, but often funding isn't sort of reflective in the need, and so we keep trying to do more with less. And then we keep trying to support staff with issues of burnout, and it's just not sustainable. And I don't think anyone has a good solution. I think that's why we keep talking about it. At Howard Center, we're constantly having conversations, client services directors, of how do we support our staff? How do we promote self-care? And also, how do we support the clients then?
Beth, we started this conversation saying really that, the numbers really aren't going up, but all I'm hearing from you throughout the course of this is that it's getting worse, and it sounds like maybe it's the acuity and not the numbers. Is that?
I think it's acuity and not the numbers, and it's the staffing vacancies. So even though our numbers aren't changing, our staff is significantly less. So that means our staff are stretched even more, our leaders are stretched even more, because if the seat next to you is not filled, somebody still has to do the work, and somebody has to cover and make sure, because our priority is client care. So I think that's a better explanation to what we're trying to describe to you, that our folks are exhausted, and we don't want them to burn out, and we want to catch it well before it gets to a level of burnout. And we're in a care business that we need to meet the needs of our clients. So it's a tough spot to be in, and you add lack of funding on top of that. You add the acuity in our community and the needs of our community, and Howard Center is often looked to like, what are you going to do about this, right. Howard Center? And we want to do something about it, and we want to be at all the tables, and we want to be part of all these conversations, and we have our limitations too. The most acute cases make it to my desk, not necessarily the everyday things that folks are hearing every day. So in addition to client care, I am worried about our staff, and I'm particularly worried about our leadership staff that are trying to hold everybody together and keep things going. And I very much want us to keep our doors open. And what keeps me up at night is what is going to have to happen for us to keep our doors open and for us to adequately provide care that we can stand behind and feel good about. Those are never easy decisions. And I think it's just going to be happening more and more. We have to figure out, what are we doing? What can we do well, with the understanding that we can't meet everybody's needs in our community, when maybe there was a time we could, because we had lots of people that were interested in working in the mental health business or the SUD business, and we just don't have that anymore. And I don't think that's changing tomorrow.
Let's see if we can maybe find something hopeful here. What are you most hopeful about?
At the same time, I'm most hopeful about the people that we do attract to work here. I think there are many mission-driven people that, regardless of a gripe or complaint you might have about Howard Center, most everyone can get behind the mission. How do we help our communities thrive? How do we help our people do the best work they can? And I just feel a bright spot every day when I meet a new staff person who's in it with us and wants to make a difference in the world, wants to make their own stamp on how to improve our society, our communities. And those people do exist. They're just a little bit harder to find than they used to be. But that's what we have going for us. We have committed, invested people that I will remain hopeful about, and I know there are more out there that want to come work here.
Dan, what are you hopeful about?
I'm hopeful that this, this need really does cause the community to rally and form some partnerships, and for those passionate people to join the workforce. But I do think that as what we're seeing, that we're going to be forced to really work together as a system, as a community, and hopeful that those opportunities arise and that we kind of rise to the occasion and come up with some good, innovative, collaborative work to solve the problem.
Heidi, what do you most want people out there in the community to know that you don't think they know, or that they have a misperception about?
Great question. I think it's less about providing new knowledge and more that I want people to remember that the clients that Howard Center supports, the people that are most struggling in our community, aren't going to benefit from our community turning our back on them. We're not going to support our community, and those people that are struggling are not going to benefit from fingers being pointed at them, from being blamed. And so what I hope is that people continue to hold a place of compassion for some of the most vulnerable folks in our community that often maybe are also the most disruptive, but those are the people that we need to support the most. And when I think about how communities function, how societies function, I think a lot of it is reflective on how we support the most vulnerable.
Beth, I'm going to give you the final word. How would you answer that question?
I would like all our citizens in our communities to take a step back from the us and them perspective. I know very few people whose personal lives have not been touched by mental illness or substance use disorders. And I just want to remind everybody, those are our kids, our parents, our brothers, our sisters, our cousins, right? We're all the same. You know, mental illness and substance use disorders, it's an equal opportunity. All of us can be at risk for getting it, struggling with it, needing treatment from it. So I hope our community, our citizens remember that to show compassion.
That wraps it up for this edition of 802 News, sponsored in part by Red Hen Baking Company. Thanks for listening.